So at the onset, I would like to thank the PCOS Society for having this wonderful initiative of PCOS in pregnancy. And I've been given a very crucial and a critical topic, metformin, insulin, which to start when. We all know that PCOS phenotype-genotype relationship is not easy. It is a metabolic disease. We know that as Asian Indians, we have severe insulin resistance, and insulin resistance is the key culprit and the root cause of PCOS. And this we have understood extremely well. So now we know that PCOS has two major complications, metabolic complications and reproductive dysfunction. And ideal treatment should be the one which attacks both these targets. So let us look at evidence in science of use of metformin in PCOS. Clearly, we have data beyond reasonable doubt to document that metformin acts at each stage in the woman of PCOS by improving insulin resistance. It is a metabolic regulator, it's an insulin regulator. PCOS with menstrual irregularities, it improves menstrual irregularities in hirsutism and androgen excess. In an ovulatory PCOS, it improves ovulation and increases the pregnancy rate. In PCOS who are undergoing IVF, it prevents an ovarian hyperstimulation syndrome and increases the live birth rate. During pregnancy in PCOS, which is my topic today, it significantly reduces miscarriage rate and reduces the risk of GDM. And in metabolic dysfunction due to PCOS, it improves dysglycemia and metabolic function. In fact, it can even be anti-cancer. And there's some very good, elegant biological data to show that metformin may be anti-cancer. So the key points of metformin in women with PCOS is that metformin is more than a 100-year-old insulin sensitizer widely used in women with PCOS to treat metabolic comorbidities to improve ovarian function. And not only does it improve insulin resistance, but also reduces insulin levels. And by that way, indirectly, the androgen production rates are reduced in a subset of women. That's why the ovulation normalizes, menstrual cycle normalizes. And this is data to show that by improving in a Taiwanese woman with PCOS, a 2-hour post-load insulin is clearly blunted by metformin. So clearly you can see BMI in overweight patients are significantly improved by metformin treatment. The 2-hour insulin level is statistically improved after metformin treatment, and outcomes of women are improved with metformin treatment with overweight. Metformin during ovulation induction with gonadotropins followed by IUI also has shown a very, very good impact. And you can see here that the metformin plus FSH has a better cumulative live birth rate compared to FSH alone. And also ongoing pregnancy rate is better with metformin, and higher clinical pregnancy rate is also seen. And overall, the health-related quality of life with metformin with PCOS has been impacted. And clearly you can see here from a mixed effect model analysis that metformin improves health quality life in PCOS women by psychological issues like acne, hair fall, infertility, and overweight hyperandrogenic profiles. So clearly metformin has an impact as a treatment intervention in high-risk females, and all the metabolic issues are important. But today my core topic is efficacy and metformin in pregnancy, complications in women with polycystic ovarian syndrome. And this was a very elegant meta-analysis published almost 5 years back, where they took 5 studies with PCOS women with metformin throughout pregnancy with 427 controls, because we are in an era of evidence-based medicine, just to get conception which were included. And clearly you can see Vanki, Begum, Katab, and those are the 5 studies which have been taken here, whether it is GDM, whether it is P, whether it's miscarriage, whether it's premature birth. You can clearly see the graph. Metformin throughout pregnancy can reduce the relative risk of miscarriage and premature birth. So this is the high impact of metformin, and this is the core of the topic today, that it reduces the risk of miscarriage, it reduces the preterm birth incidence in PCOS in patients without any serious side effects. So are there guidelines? Well, use of metformin in PCOS, the RCOG says, can be considered in women with PCOS who are already undergoing lifestyle treatment, and the NICE guidelines are very, very similar. And if you see the International Society for PCOS, again has endorsed metformin, which Dr. Durusha was a member of. And again, in the Indian population, clearly we know that metformin has data as an effective combination therapy, reducing androgen excess levels. And metformin clearly has been shown very, very impactful in the Asian Indian women and is the need of the hour. But metformin in pregnancy is just not reducing insulin resistance. It also has a role in GDM. So what is the role of metformin in GDMs? What is the evidence in science? You know that metformin is a wonder drug. It has an impact on gut microbiota. It has an impact on obesity, fatty liver, atherosclerosis, Alzheimer's disease and memory, PCOS, precocious puberty, including antimicrobial action. So now, obviously, when we use metformin in women's health, today the main topic which was given to me by my good friend Dr. Uday Thanawala, and I would acknowledge his contribution to the PCOS society, is the impact of PCOS and GDM. In PCOS, metformin has a mild androgen effect, reduces risk of miscarriage, is a second-line ovulation agent, and decreases OHSS and IVF. In GDM, the data is very robust to show that it reduces weight gain. Its efficacy and safety is comparable to insulin. That's what I wanted to show, and that is the other or either or metformin or insulin. It reduces the risk of miscarriage and decreases the risk of neonatal hypoglycemia, which is so crucial. So this is the first data to show 7 women who were treated with metformin during the first trimester. It's a very, very old paper, 1994, which was by Pedersen et al., who has a lot of work in GDM, and you can clearly see that a congenital malformation of occurring diabetic woman with OHS, metformin was less. So no major congenital malformations were seen in infants with diabetic women treated with metformin at conception in the first 8 weeks of pregnancy, and there were no obvious indication for therapeutic abortion. So it doesn't have any impact on embryogenesis. Well, obviously, Dr. Avdesh Kumar Singh also wrote an article, Metformin in Gestational Diabetes, an emerging contender. A lot of recent evidence suggests that the outcome of metformin is RCT's meta-analysis, ease of use, acceptability by patients, lesser maternal weight gain, lesser maternal hypoglycemia. And if you look at a systematic meta-analysis, 42 clinical trials, 8,956 patients with GDM, you can see that clearly when you see head-to-head insulin versus metformin, metformin is the most effective in reducing the risk of complications compared with insulin or glepanclamide both. So this is hard data. Large for gestational age, macrosomia, neonatal intensive care admission, neonatal hypoglycemia, cesarean section, and preeclampsia are highest with insulin and with glepanclamide. They are insulin providing therapies, and metformin has the lowest because remember PCOS is a insulin resistant state. And this is data of metformin versus insulin head to head. And you can see here in this study, which was published almost 7 years back, 27% of women using insulin and 27% of women using metformin achieved adequate glycemic control in the first week of treatment itself. And when you look at neonatal outcomes, metformin is an excellent alternative for insulin in treatment with GDM with fewer complications for the fetus and better maternal acceptance. So if you look at clear data, okay, on meta-analysis, metformin treatment in the first trimester has a statistically significant 57% protective effect. And the basis of that data, there is no evidence to consider that there is an increased risk of major malformations when metformin is taken in the first trimester of pregnancy. And this is the meta-analysis very clearly saying metformin is not associated with any increased risk of major malformations. Metformin can cross the placenta. Yes, so what? A lot of people are scared and they will tell you that metformin crosses the placenta. Metformin has been shown significantly to cross placenta with fetal concentrations at half of maternal concentrations. In a common clinical setting, before pregnancy like pre-GDM, GDM, PCOS, the therapeutic dose of metformin is poorly defined. And that is between 5 grams to 2.5 grams. The transplacental passage of metformin is from the maternal to the fetal circulation occurs through the organic cation transporters, the OCTs. But the data is very, very clear cut that there is no real impact. It does not stimulate insulin secretion or release, does not cause hypoglycemia. It, however, enhances the insulin action, stimulating the glucose uptake in the liver and the periphery, suppressing the hepatic glucose output. So clearly the data is that metformin helps you to get pregnant. It is useful in insulin resistance syndrome. It prevents early pregnancy loss. Particularly, it reduces the first trimester pregnancy losses in women with PCOS. And this is hard evidence head-to-head in a placebo-controlled trial. You can see metformin versus placebo. The impact is clearly there that the early pregnancy loss rate from 41.9% in placebo comes down to 8.8%, statistically significant. And the history of prior miscarriage from 58.3% comes to 11.1%. And this is, of course, the big trial in 2008. Women with GDM, metformin alone or with supplemental insulin was not associated with perinatal complications compared to insulin alone. And women preferred metformin to insulin treatment. And this is another data to show the MEET-TY study, which was Bernie Zimmerman's study from Canada and several other authors from Australia and Canada, showing metformin versus placebo, randomized. Metformin had several maternal glycemic and neonatal adiposity benefits. So this study, the Canadian-Australian study, MEET-TY study, showed that women in metformin group had a better glycemic control, required less insulin dose. Women with metformin group had overall less weight gain and less weight per week Fewer women in metformin group had cesarean sections. Fewer women had lesser serious side effects in metformin groups. And there was no difference between women who received metformin and those receiving placebo on neonatal morbidity and mortality. Obviously, the large international population showed there is no exposure to congenital anomalies, and clearly we know that the outcomes are excellent. And the guidelines, whether it's NICE guideline, WHO guideline, Australian and Canadian guidelines, and even now the Indian guidelines from the Diabetes Society clearly show that the guidelines need to be modified to include metformin in GDM. And more data is available. We firmly believe in India that GDM is an insulin-resistant state, and you need to give metformin there. So obviously, from preconception to postnatal period, NICE guideline is very clear about their outcomes of metformin. And Diabetes Canada has put insulin as first line, but metformin is a reasonable alternative. They have clearly said good safety data in pregnancy, evidence of less maternal weight gain, less large for gestational age, less neonatal hypoglycemia. Women should be informed that it crosses the placenta, safety data of offspring for 2 years, and insulin is necessary in 40% of women with metformin, so you need to indicate that. The FIGO guideline in 2017 clearly says that in insulin, glibenclamide, and metformin are all safe, effective therapies in GDM in second and third trimester and can be initiated as a first-line therapy. And they have clearly said metformin is a better choice than glibenclamide. So metformin compared to insulin, the ADA 2021 which just came out, clearly has shown, and these guidelines were out just a week back, clearly show metformin is lower risk for neonatal hypoglycemia, lesser weight gain, and it readily crosses the placenta, resulting in umbilical cord blood levels higher than the maternal levels. So what's the choice? Metformin safe, no risk of hypoglycemia, more compliant, benefits, cheap, effective. Insulin, hypoglycemia, weight gain, fear of injections, and sometimes very low glucose levels. So obviously metformin as oral therapy has a clear advantage in compliance, hypoglycemia, appetite, weight, and injections, and successfully overcomes all the barriers. So when I summarize the evidence in the pregnancy, clearly in GDM, it has a good safety profile for mothers, reduces severe hypoglycemia versus other agents, head-to-head trials are available, reduces pregnancy weight gain head-to-head versus insulin, similar effects in newborn health, and no impact on the offspring, on blood pressure, motor, social, linguistic development for 18 months to 24 months. And there is no fetal impact, no convincing evidence to show increased incidence of congenital malformations or miscarriage, long-term health or metabolism during adulthood. We know pregnancy is a tissue culture experience, and we know that the critical implications of maternal metabolism in fetal development, and we know that in the fuel metabolism in normal pregnancy, there is a diabetogenic stress in the second half of pregnancy, which is insulin resistance, and that is where the insulin goes up. And therefore, we believe that GDM is nothing but unmasking of insulin resistance due to a diabetic stress test. So if somebody is predisposed to develop type 2 diabetes just because of pregnancy in second trimester, because of carb loading, you get classically the impaired glucose tolerance. If you use insulin therapy in pregnancy, it is weight into 0.7 first trimester, weight into 0.8 second trimester, weight into 0.9 third trimester. In 30 to 40% of women, despite of metformin, sometimes you need to use insulin, but that's not our first choice. So obviously, when you have the choices, I summarize that metformin, safe, no hypoglycemia, compliance, cost-effective, benefits and protective effect during pregnancy, which insulin does not have. And therefore, globally, in the endocrine world, our preferential choice is metformin, followed by insulin. And that's a clear thing. I hope what you have listened to me, you have will learn something from this lecture about metformin over scoring insulin. But when insulin is needed, don't bypass it. If it's a type 1 diabetic, you need insulin for life. And what you listen and learn today, you will adapt. I wish all of you a very happy 2021. I wish that you get good sleep in 2021 for at least 7 hours from 10 p.m. to 5 a.m. Please do a 2-hour digital detox every day. Sleep on time and sleep well. And thank you very much for allowing me to present a very interesting topic of metformin over insulin in PCOS pregnant patients and how metformin now is coming out with a good level of evidence in this space. Thank you very much, Dr. Thanawala, Dr. Durusha, and the entire PCOS society, which we are all a part of. Thank you very much.